Good afternoon, and thanks for joining us for today's brand new Healthline. I'm Courtney Butts, and Healthline 3 is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering those questions that you have live in the studio today. Those phone lines aren't open just yet, but they will be in just a couple of minutes. But as a reminder, make sure when you do call, you're in a quiet room with your TV turned all the way down if you're tuning in on your TV. That number to call is 318-219-4569. It will also be on the bottom of your screen. Today, we're talking about youth sports injuries and prevention. Joining us today to talk about this is Dr. Mark Callanan, attending orthopedic surgeon and director of sports medicine with Willis-Knighton Orthopedics and Sports Medicine Piermont. Thanks for being here.
Always good to be here.
Absolutely. So first, I just mentioned a little bit about what you do at Willis-Knighton, but kind of go into a little bit more detail about what that means and what does it mean to be the director and an orthopedic surgeon? Yeah.
So, we've talked about this before when I've been on these segments. Sports medicine is a very broad, encompassing area of orthopedics where it's not just the youth athletes. We take a lot of care of the local teams and high schools at Willis-Knighton in particular. We have a very good system for sports medicine, but that's everything from these kids that are adolescents all the way up to, grandma and grandpa, that still like to get out and do stuff in the yard and garden and develop, tendon or musculoskeletal issues at that time, and we'll treat that broad spectrum. That's kind of the cool thing about sports medicine.
Yeah, I love that you kind of mentioned the spectrum because I think usually we think about elite athletes, kids in high school that are playing football or college athletes, but it really can encompass, so many ranges, especially those people that are like weekend warriors.
Oh yeah, 100%. Very broad range of them. The reason we were kind of focusing today on the youth, or why I thought it would be interesting, is because, going back to what I do as director of sports medicine, we employ, I think, 15 athletic trainers right now. They are all employed by Willis-Knighton, but they're dispersed out throughout the high schools, all through Caddo and some through Bossier Parish. They provide really daily interactions of care and management of these athletes and help kind of really crucial role in making sure that if some kid is not progressing back from just what they'd assume would be a more minor injury, that they can get them in with me or one of my partners to get the appropriate evaluation and treatment that they need. And they also help with aftercare and everything else, along with all of our great physical therapists. So it's really a cohesive team, and being the director just means that I get to help with management, making sure we get care and policy and equipment and all this different things that are all part of this multifaceted team that we have at Willis-Knighton Sports Medicine.
Right, and I think you mentioned that before we actually started rolling, you've got a project in the works.
Yeah,
right?
Yeah. So as we kind of alluded to in the entry segment, youth injuries in sports has increased over the years. The CDC was actually kind of determining this as an epidemic. 3.5 million kids, 14 and under, are going to get hurt per year. I think there's a statistic around 30% of children playing youth sports will sustain a serious injury, meaning may require surgery throughout some point in their career. And so other estimates from studies show that almost 50% of these things are preventable. So that's really where it comes to us as providers. Obviously, being orthopedic surgeons, we love the surgical side of things. But if you ask any good orthopedic sports surgeon, one of their priorities is keeping kids off the table. We're great and want to provide the absolute world-class care to get them back and fix them with the most modern, up-to-date techniques in sports medicine and treatments and data-driven care. But at the same token, if we can find ways to keep those kids from sustaining a potentially catastrophic or career-ending injury, that's absolutely going to be our focus. So getting back to kind of what I mentioned, this is fairly new. We are looking at different things that we can do since we do an annual physical day. So obviously we have all these kids that come in, and it's a very generalized screening. We're really looking for things like risk factors for cardiac arrest events or asthma and different things that are really the more acute. But ways to kind of tease out and find kids that have risk factors for ACL tears. Looking at lower body mechanics, that's one of the more, ambitious projects I want to try to do, where we try to get a preseason screening from all athletes, males, females, all the sports, and see if we can identify neuromuscular movement patterns with force plates that would predispose them, so we can ideally identify these kids and get them in the appropriate kind of preconditioning to avoid them tearing an ACL or having an issue moving forward. But that's still in the works. That was just
no, that's awesome, and that's a great option because I think a lot of times kids that are in sports, they don't really think about what can happen if they injure themselves, or what if it is a career-ending injury? And something like an ACL tear that takes a long time to recover from.
Yeah.
And especially if that happens like their senior year, that
Oh,
can
yeah.
be devastating. So definitely want to maybe get that at the forefront of their minds when a lot of times at that age you feel invincible and like that's not going to happen.
100%, 100%. Most athletes never expect it to happen to them until it does.
Right.
And that was another topic where when you're thinking about the prevention side of things, we talk about specialization in sports. This is becoming more of a national thing where kids earlier and earlier are no longer playing a multitude of sports and getting that generalized, well-rounded motor skill development that is really recommended by most healthcare practitioners, especially in the sports medicine realm. Instead, they're starting earlier and earlier thinking it's going to get this competitive advantage. Baseball is very much especially popular here where kids start very young trying to get into pitching camps and training and year-round baseball, throwing, and stuff like that. Specializing too early, we have literature showing that it kind of slows down the development of really a complete, well-defined elite athlete, by just focusing and honing on a very specific subset of skills. If you look at, every year the NFL will put out of the Super Bowl winning team, how many of these guys were multi-sport athletes? Almost every team, it's over 90%. Okay, so all these guys were very well-rounded, and when you look at elite level baseball players in particular, large majority of them were high-level athletes in multiple different sports, and the baseball was one of the realms they ended up in. But the one thing that you will notice about the people that specialized earlier is there's studies showing up to twice the amount of injury rate when you just specialize earlier and you don't do that well-rounded kind of generalized development that starting in the adolescent or certainly kids should be doing, and then specializing later as they get older, as they get closer to college, if that's the route they're going. That's really one of the biggest risk factors that we found.
Interesting. Yeah, and you would think it's kind of counterintuitive. You'd think if you start earlier that it would help you. But
exactly. There's some of it came from when you look back at the specialization. I know there's a person named Erickson that published the 10,000 hour rule where they looked at specialization and came up with the number 10,000 hours of focused training, really dedicated to a craft. That's how you become the expert level. The unfortunate side is that's been extrapolated to sports when really they were looking at things like chess and being a musician and developing different career skills, and trying to factor in those 10,000 hours to a sports standpoint where you have youth kids and the amount of stress and strain from those repetitive overuse injuries, it just doesn't really mesh well. And that's where we're trying to spread a little bit more information that it's probably not best to get your kid in that specialized program. There's a famous strength trainer named Mike Boyle, and his joke was kind of like, he doesn't need specialized training. He needs a friend and some, bike and some friends. Go out and play, do something else, have fun, enjoy life, do multi-sport development.
I love that. That's a great perspective, and probably something that can carry over just in lifelong as well.
Absolutely. Burnout rates are much less when they're able to kind of do multi-sport stuff, not to mention, again, we're talking about injuries. And since we touched on baseball, pitch counts, that's one of those things too, where, I don't want to harp on just one sport versus another. Obviously, we got football coming up, and they're the number one, statistically injured population of youth sports. But we do see a lot more baseball players. I had the honor and privilege of training with James Andrews, who is a very famous orthopedic surgeon, very big pioneer in the sports world, treated a lot of baseball players. And he noticed over the course of his career, he was seeing children filling up his waiting rooms versus what used to be adult injuries. And a lot of this has to do with us specializing earlier. Kids trying to throw year-round, where current recommendations are at least 3 to 4 months that you should be taking time off from throwing. Doesn't mean you can't play a sport, but you should go play something else that doesn't involve throwing. Let that arm heal. Let that arm, care happen. When you think about things like showcases, where they, pay money to go thinking they're going to get picked up, stuff like that, a lot of these require an athlete to be at high level, ready to pitch conditioning year-round, which is just not healthy. I mean, most baseball players, from the time they start to the time they're ready to throw off a mound, that's like an 8 to 10 step, progression that they should all have. Not to mention, you need to be taking those 3 to 4 months off in time. So a lot of showcases, unfortunately, are kind of not during the peak seasons because they can get more kids there, but that's when they should be resting.
Right.
And so you get them out there, you get a bunch of competitive kids thinking this is my shot, you get a radar gun out there, everybody's focused on velocity now, you're just asking for injuries. And again, my mentor, James Andrews, hated showcases. He thought it was one of the big, driving factors. And in fact, I've seen studies where they looked at kids that ended up having elbow surgery. One of the big factors was the ones that had it through almost twice the amount compared to the ones that didn't. And when they looked at showcases, they went to 4 times the amount of showcases compared to the ones that didn't. So there's just a lot of driving factors, and a lot of it has to do with year-round play in a very specific sport and specializing too early.
Gotcha. Makes sense. Okay, well, if you're just joining us and you have a question for Dr. Mark Callanan, you can give us a call. Those phone lines are open. That number is right there on your screen. It's 318-219-4569, and we are talking about youth sports injuries and prevention. So give us a call. So going back to those injuries, what are the most common ones you see?
So it depends really by sport. Obviously, from a lower extremity injury standpoint, ACL tears, devastating, but also very common. Meniscus tears, cartilage injury, different things like that within the knee, also common. Patella dislocations, where the kneecap actually pops out, very common. And these are also things where, when we're thinking about screening for risk factors, this is very pertinent, not just to males, but also to females. You know, when you look at ACLs and people think, hey, football, I got clipped from the side, I tore my ACL. That does happen. There's traumatic ones, but really all comers, it's around 70% are non-contact, meaning that athlete is just running out, goes to make a cut, and their coordination, their mechanics, whatever it may be, their strength, you know, weaknesses and balances, different things like that are just not in play, where you get it just right and they pop that ACL without anybody touching them. So we see this too when you break it down by gender. Females have a much higher percentage of non-contact ACL injuries versus males. And so again, if there's a way that we can look at these things, and there's a lot of good data and a lot of screening, I'm saying from Willis Knight and a way we can provide for the community, my idea is if there's a way that we can identify some imbalances that we know put you at risk, and we can work to correct these things to develop that you know, the neuromuscular coordination, the power, all the different things that help prevent ACL tears or lower extremity injuries, I think that's a great thing.
Do a lot of the same things that prevent the ACL prevent the other injuries you mentioned?
It certainly can.
Yeah.
It certainly can. You know, ACL is just one of the big ones because we see so many of them, but really any lower extremity injury, and again, having data and trying to extrapolate that out to injuries and seeing what we can find kind of correlates, I think would be, you know, just good overall for the population, and hopefully a service that we can provide. But otherwise, we have great athletic trainers too, and I think that, you know, between our athletic trainers, our good sports therapists that we have, and then obviously we got a great team of surgeons. You know, it's one of those things where we have kind of comprehensive care, ideally from A to Z for any of these athletes. Right.
Okay. So majority of the time with these injuries, it's maybe the imbalance in the lower extremities.
Certainly. Yeah,
or not
and some
warming
people,
up properly.
Exactly, and just some people, it's the way you're developed too. You know, different. If you think about the alignment of hips and knees and the way some people just naturally are, you see some people a little, you know, knock-kneed, a little bow-legged. There's different things that are out of their control, but are risk factors that, you know, we should be aware of and just say, hey, you're at higher risk based on your position, your sport, whatever it may be, and do whatever we can from a prehab or preventative standpoint to kind of correct those things. So that's really looking at the lower extremity side of things, but you know, again, we kind of touched on baseball. I think sometimes it's hard when you're looking at trying to figure out when is it time to come in and see a physician, you know, or what is something we could just kind of work through or play through, you know, or even how much volume of athletics should I be playing? How much should I be throwing? What is the rest period for my age group and this and that? So there are some great online resources that I think are really important. The National Council of Youth Sports actually came up with the Stop Sports Injury Program, STOP is an acronym, Sports Trauma and Overuse Prevention. And this was in combination with one of our big societies. I was just at their meeting last week, the American Orthopedic Society for Sports Medicine, AOSSM. They kind of come together with a lot of leaders in the field, clinicians, you know, athletic trainers, PTs, and they have a full website that you can find where it's broken down by sport, what the recommendations are, specific injuries, kind of gives you a generalized overview of these injuries and what options are, as well as, you know, some of the symptomatology, some of the things, hey, if my child is complaining about X, Y, Z, is this something, you know, we could just kind of work through, or hey, this is actually a real injury, we need to go get this evaluated. So I do think having a resource like that is really good. That's where I often try to refer some of my younger patients to, or if coaches or trainers or anybody are looking for literature, that's one of the good sites for that.
Nice. Okay, so let's say that we have maybe someone in high school and they are interested in doing this prehab that you're talking about. Is this something that you provide as a service at Willis Knighton?
It would be something where ideally we can get you plugged into the right people. You know, with sports PT, you know, physical therapy, having people with good experience and a lot of times specialized training is really important for that. Certainly we have a lot of great providers at Willis Knighton, and we try to get people involved with our, you know, especially our sports trained providers, but there's a lot of great therapists in town between the training ground, Foltz, you know, there's a lot of good people that we also work, because we understand people will go out everywhere in the community. So I think there are people that we try within our own system, and then externally, if people are going external, that have a very specific skill set that can help with those things. And I think, you know, the prehab side of things nationally is very underutilized a lot of times, unless you start getting at the higher up levels, where a lot of times these guys are already kind of in a good spot because they made it that far, you know, versus the ones unfortunately filtered out due to injuries earlier in life.
Yeah, right. I know, because you see a lot of times where maybe it seems unattainable because you have, it's maybe an expense for, like, you think of these elite athletes that are doing all of these very specific exercises to get ready for competition day, and sometimes it may feel like it's out of reach because it's an extra expense, but it actually maybe is just something that's not, you know, talked about enough, and so that's something that you feel like Willis Knighton's kind of trying to do.
I think so. I would love for us to be able to have a little bit more of a role in the prehab side of things. We'll see what we can do. You know, obviously we are more than happy and more than capable from the surgery side of things. You know, we do a lot of ACLs, a lot of patellofemoral stabilizations, you know, dislocated shoulders, cartilage work, all that stuff. You know, we'll give you the latest cutting edge of what that is, but again, I think if we can get to the point where we can also provide a secondary service outside of just the non-operative and operative management when you get that injury, I think that really gives us kind of the full comprehensive sports medicine picture. Nice,
I love it. Okay, so you mentioned time off from sports and maybe just time off in general. How important is that recovery time for an athlete?
I think that's very important, you know, especially, you know, early on, not only to prevent burnout, but also as athletes are growing and developing, there's that time, especially when they hit their growth spurt, where those limbs get a lot longer, those leverages across, you know, if they're throwing across that arm, the amount of torque they can generate, those muscles are getting stronger. All those things develop a lot of times quicker than the growth plates do. So when you're talking about the earlier populations, you still haven't even gotten skeletal maturity yet. So, you know, my younger patients, we a lot of times, not infrequently, will see physeal injuries. If you talk about like a thrower's shoulder or a little leaguer's elbow, these are basically injuries to a growth plate, and that's just simply from overuse, and any growth plate is vulnerable until those things fuse. And so that's kind of on the younger side of things. So again, it's an overuse situation there. As we get older, then you start to see more of the tendon injuries, and you know, cartilage injuries can fall within that. A lot of times in younger patients, that's more traumatic, but it certainly can be attributed to poor mechanics, overuse, and, you know, just bad luck sometimes.
Yeah. Okay, and so I know that a lot of times in the sports world, you know, we have coaches, we have athletic trainers, we have physical therapists, we have people like you who are our director of sports medicine, but sometimes, and then of course we have social media. So for an athlete, what would you say is, you know, who they should turn to for advice, right?
You know, this is my thing. It's really not a single person when it comes to sports medicine, and that's kind of the art of what we do outside of the hospital, outside of the OR, is really you're working with a team of people. And at the end of the day, you know, you have your coaches, you have their staff, you have the athletic trainers. They're kind of the forefront, you know, and my athletic trainers are essentially on the front line at all times. They're the ones seeing these guys every day. They know who, you know, never complains and all of a sudden starts complaining, and this may be something real, versus, hey, this is, you know, every day something is coming up with this individual athlete. So they're the ones who know them the best. They know when somebody's, you know, a little bit concerning or not. And they can also do some rehab and do some individual training room stuff. And if they're not improving, then kind of move on. So I think there's that. And then there's also, you know, making sure the coach is on board and the coach is well aware of what's happening. You know, the communication with the rest of the team, especially with an injury, you know, making sure the parents are comfortable with your opinion, making sure the coach is on board with things, the athletic trainer is filled in with things. It really is a cohesive group. But I do think a lot of it starts with the athletic trainers that we provide to all the high schools and making sure that they are in communication with their coach about this athlete not getting good. Now, hey, they're kind of past the point where we think they're not getting better and we need to get them in to see a provider. So it's really not as simple as I'm the only guy to come and see.
Right.
Anybody telling you that, I would turn around and walk out. I'm more than, any good surgeon should not be, mad if somebody goes somewhere else or wants another opinion. I think that's excellent, especially when you're talking about youth athletes and injuries and the treatment of those injuries.
Right. Okay. So we've talked a lot about prevention and, those good tactics, but what if someone, like you said, gets to that point where it's not getting any better? What is your typical workup in the clinic? Yeah,
absolutely. So it depends on the body part, and it depends on the clinical exam. And a lot of times in my lower, my younger populations, especially if it's something where this athlete has been flagged by the trainer and the parents are concerned, yes, you can do trial of conservative therapy, prescription anti-inflammatories, throw a little steroid at them, but I have a lower threshold to get an MRI or advanced imaging. Obviously, we start with basic x-rays, make sure there's nothing fractured. Most fractures declare themselves pretty quickly, though. It's something pretty obvious where they would go to the ER after a broken bone and find it. It's rare, but on occasion, they'll kind of walk into clinic. But we always start with the screening x-ray, and then again, I have a low threshold to get an MRI, which will show us everything we don't see on the x-ray, the cartilage, the ligaments, the tendons, all that stuff, and that's really where we can really kind of assess the actual level of the injury. From there, it depends on what we see, kind of how how bad the symptoms are for the athlete, what we actually see on advanced imaging, how our clinical exam correlates to all this stuff. Then again, if we can get an athlete better without cutting on them, that's always the goal. So then you start talking about injections outside of the medication, directed physical therapy where we get them plugged in, we shut them down, we give them a trial of these things, or in certain kind of more catastrophic injuries, if we know, hey, this is not going to get better, it needs to be fixed, we'll talk about surgery.
Okay. Is there ever a sports injury, or what would you consider an emergency sports injury that needs to be addressed with surgery immediately?
So, the true emergencies really are going to be any type of, major fracture that we have, dislocations if they're stuck outside the joint. Anytime you're worried about a chest or a head injury or anything like that, those are the things that happen on field. That's not a clinic follow-up. That's like a trip to the emergency department. Those are really the more emergent type of things that we see. Somebody can tear an ACL, and certainly that's something we know. If you want to keep playing sports and just living life, and younger, athletes, we fix those things. Luckily now we've come up with more technology where we're actually trying to do repairs in some of these populations if the tear pattern is amenable and there's still enough of a good stump. We offer that at Willis-Knighton. It's called the Bear Repair, and it's basically a little scaffold we can put in there to allow these things to heal, or we do a reconstruction, which is more common, based on the tear pattern. But stuff like that, ACL tears, or let's say somebody, dislocates a shoulder, it's popped back in the ER, all the, even a sublux patella pops out, we pop it in. Most of these things can be treated, electively, where, depending on the severity, some may require surgery sooner than others, but most ACLs, you want to get their motion back prior to undergoing surgery. So they'll be in a trial of physical therapy to get that motion back even prior. So it's not something emergently that I see in clinic and the next day we have to operate on this. That usually falls into the purview more of fractures and different things like that, which usually get screened out in the ER.
Gotcha. Okay. And usually maybe on the field.
And on the field, absolutely. Absolutely. Like, okay, concussions fall into that too, bad concussions. Not every one of them has to go get advanced imaging, but we also have my non-operative sports provider, Dr. Lee. He's concussion trained. There's a very specific protocol. We actually are now getting a therapist down at Willis-Knighton South's physical therapy department that's specifically trained in some of the kind of rehab protocols for concussions, which is hard to find. So that will also be something good that we can funnel some of these athletes down there to help kind of get them along the pathway a little bit quicker after getting a head injury. So we're trying to really provide the most comprehensive care from A to Z on these things.
Love it. That's awesome. So you have several different specialties within your clinic at Willis-Knighton. What do you specifically just focus on? Sports, right?
I do sports. Okay. So again, that encompasses, I do A to Z on shoulders, everything from, if you have a high school kid, what are we going to be operating on the most in a shoulder is probably a dislocation where we're fixing what's called the labrum, tightening up the shoulder a little bit again. All the way up to my adult populations where we're doing shoulder replacements, and then from the knee standpoint, I do a lot of cartilage work. I'll do ligament reconstructions, meniscal repairs, different things like that. The meniscus being the little shock absorber discs that often get torn. And depending on your age, there's different treatment recommendations with that. There's kind of a whole lot that goes into that. And then elbows, certainly from the thrower standpoint, we see a lot of throwers' elbows. People can tear that Tommy John ligament, as they call it, the ulnar collateral ligament. We do repairs and reconstructions where we're at. We can scope elbows if people have little bone fragments or cartilage injuries, so we can offer pretty comprehensive care on that. Some of my other partners focus more on the adult side of things, where they're doing, hip and knee replacements. In more the older adult arthritic populations, we have, spine surgeon there. So we really have a pretty comprehensive group.
Yeah, for sure. Okay. So going back to, you mentioned the thrower's elbow. So going back, we talked a little bit about, of course, baseball showcases and multi-sport. You recommend more of the multi-sport approach versus the specialized sport. But we didn't really talk, you did mention pitch counts, but we didn't really talk about what are those recommendations. So I'm curious.
So pitch counts, so that's good. So getting back to that stop injuries, if you look on that website, because a lot of times people will kind of go in one ear out the other, trying to remember what you tell them in clinic. So if you can refer them to that, they have a chart that breaks this down nicely. I think around 7 to 9 years old, it's around 50 pitches max per game. And then that goes up to kind of the 16 to 18 population, where it's kind of 95 to 100. So it gradually increases on the recommendation per year, but also within that, the amount of pitches based on the age group, they also give recommendations for how many days off they should take before their next outing of throwing. And then, again, they break down everything from how many months they recommend off on the different sports, the very sport-specific injuries and all that, and kind of what their recommendations are, not just in baseball, but kind of beyond. But in general, that's kind of the baseball rule of thumb. At least 3 to 4 months off per year, ideally. Watch the pitch counts. There's a very specific recommendation starting around 50, working their way up to around 95, 100 in those more, 16 to 18 more skeleton mature patients.
Okay, yeah, so definitely refer to that resource if you have the specific questions, or the athletic trainers and the team should also be monitoring that as well.
Certainly. And if, people are developing, shoulder or elbow issues, especially in throwers or young athletes, that's not a normal thing. And unfortunately, there are some that we see where it's like they've been chewing on, ibuprofen or something for a couple years. There's some tough kids out there kind of grinning and bearing it, thinking, hey, this is just normal soreness, and it's not necessarily, the case. So certainly if you have something where it's a lingering issue for you, or your child has kind of always been dealing with a nagging injury, it's probably not a bad idea to get it checked out. And again, it doesn't mean they need surgery, but it's good to have more information, more resources, maybe get them plugged into therapy, different modalities that they can do there as well. But there's a lot that kind of goes into that, and I think neglect sometimes, unfortunately, turns something that could have been treatable non-op to an operative issue.
Yeah, and then that could be what that career-ending injury, and that's definitely what we want to prevent. Okay.
Certainly could.
So we only have a couple minutes left, but typical for the surgery side of things, I know that this is going to be a very broad question, but recovery, what does that kind of look like from, I guess, the spectrum of what you treat?
So that is a very broad question.
It can be anywhere from
a
weeks
rule
to
of
months.
thumb, ACLs, about 9 months, from the time of surgery recovery. I always tell them it's more of a marathon than a sprint, but there's a lot of different metrics that we look at before they're cleared, and that's really an individual athlete basis. But then going up to shoulders, all that stuff, usually it's several months at the very least,
Yeah.
And so that's a pretty broad. I could probably talk for an hour on how long it takes individual stuff.
ACL is probably the most common one that people refer to, and it's a pretty, like you said, it's a marathon.
But if you have to do a Tommy John, that's a year to a year and a half, so that's a very long operation. So again, getting back to preventing kids from getting on that table, that's at least a season, if not 2, depending on the time of year. So very serious stuff.
Yeah, definitely. Like you said, it's not doesn't seem real, or that it can happen to you until it does. So it's important to have those conversations, if nothing else.
Absolutely. So. And sometimes it's just bad luck, despite everything.
Right.
So as much as we try to catch the ones that we can, and that would be, I think, any surgeon's goal is to help work on preventative measures. We're always here for those ones that kind of slip through the cracks, and more than happy to take care of them.
All right. Well, great. We have about a minute left, so tell us where we can find you, and if somebody's wanting to get plugged in with Willis-Knighton Sports Medicine, do they need a referral?
You can actually find us on the website too. We're called to make an appointment. I think some insurances do require a referral, but we're usually pretty good about getting people in as quick as possible. We're at, now it's called the Orthopedic Clinic at Piermont. And so not just the orthopedic clinic, but it's 318-212-3610 is our clinic number. And again, there's online options too for referrals and stuff like that.
All right, pretty easy to do. And this will be on our website. This will be on ktbs.com/podcast. If you missed this episode or if you wanted to rewatch it, with Dr. Mark Callanan, Director of Sports Medicine at the the Orthopedics Clinic at Piermont, right?
Just Willis Knighton overall.
Okay, yes, okay, got it. Well, thanks for joining us,
Yeah,
Dr.
absolutely.
Callanan, and thank you for joining us.
All right.